So when a patient is not improving, all of us start getting uncomfortable. सब टेस्ट भेज दिया, antibiotics भी start किया. I escalated the antibiotics also, and I kind of think that the diagnosis I have made is also correct as per whatever is the available results from the tests which were sent. But patient just doesn't seem to be improving. So in such situations, these which are like typical 3 a.m. moments which make us very very uncomfortable, what we need to do is instead of asking why that particular patient is not improving, we should just step back, take a pause, think over and ask ourselves, am I missing something in the diagnosis, course or treatment of that patient? And then suddenly, with the same information and same clinical science, things may start becoming more clearer, and we are able to do something which can help that patient in improving. So in today's video, we'll discuss some very common scenarios which we see in day-to-day practice, where in spite of feeling like we have done everything right, the patient doesn't seem to improve. So in the first thing, so there is a middle-aged farmer lady from Andhra Pradesh who was brought to our hospital with history of severe myalgia, for which she was taking painkillers for 3 to 4 days, followed by fever of 4 days duration, after which she had drop in platelet counts, increase in creatinine, and that's why she was brought to the hospital and admitted. Now, her initial labs did show that the platelet counts were gradually dropping. The WBCs were kind of okay. Creatinine was 3.2, urea of 140. With hydration over next couple of days, the creatinine and urea started improving. Simultaneously, her blood report showed dengue IgM positive. Ultrasound which was done did not show any features of chronic kidney disease or obstructive pathology, but it did show mild ascites, mild hepatomegaly, and slight area of pleural effusion bilaterally. So at this point of time, everything looked quite set. Fever, body pain, dropping platelets, polycystitis, AKI, dengue IgM positive. Fine, everything seemed quite picture perfect for a patient with dengue. But over next 2 to 3 days, even though her renal functions were settling with better hydration perhaps, the lady continued to have worsening sensorium. She developed altered sensorium and irrelevant talking. She developed neck rigidity, and her platelet counts kept on dropping further and went below 50,000. Now that's when we started rethinking our diagnosis of dengue. So at this point of time, what should we do? Should we add antibiotics? Should we do the workup to say that it could be dengue HLH and do your say ferritin, LDH, triglycerides, start her on steroids, or repeat the dengue serology titers to see if the titers are increasing, further confirming the same diagnosis which we thought in the beginning, or are we missing something over here? So in this situation, we need to take a brief pause and ask ourselves, is this disease behaving the way I expected it to behave? And then look at the whole findings all over again. So now suddenly you see a little bit of different perspective. You have a middle-aged lady who is a farmer in rural parts of Andhra Pradesh. Secondly, all through her labs, if we observe, even when platelet counts kept on dropping, the WBC never dropped. In fact, if at all, it has slightly started to increase. Although her creatinine settled, liver enzymes seem to have worsened. And more importantly, clinically, her fever has persisted and she has now also developed altered sensorium and neck rigidity. Now this tells us that this is not behaving like what I expect in dengue fever. Because typically in dengue what we expect, by 5 to 7 days max, even if there is a second peak, the fever does subside. Secondly, most important, if we see the pattern in dengue, when the platelets drop, a day or two before that, WBC would have already started to drop. So thrombocytopenia, which is worsening in absence of leukopenia, that is an alarm that this may not be dengue in first place. Secondly, when we observe dengue patients, most often it is that day in their course where fever is actually about to reduce, but that is the day when we find the counts dropping the most. Again, in this patient, fever continued even when the platelets were continuously dropping and WBC counts never dropped. So this made us think, okay, this is not dengue perhaps, and we sent rickettsial PCR, thinking maybe scrub typhus, although she had no rashes anywhere else. But that's when we examined her again. By now, she had started developing subtle dusky bluish discoloration of her fingertips. So digital gangrene perhaps. Again, something which is not commonly observed in dengue, but is quite well reported in rickettsial infections, especially something like a scrub typhus. So we added doxycycline and we resisted a temptation to start too many other antibiotics. Parallel, of course, a guided lumbar puncture was done. The CSF examination did not show gross abnormalities, as you can see in the reports. The CSF cultures, of course, were sterile, and by that time, by another 48 hours, we had rickettsial PCR coming positive. So now everything fit in rickettsial infection, most likely a scrub typhus. Now the only next question was, do we start corticosteroids in this patient? Maybe dexamethasone, maybe methylprednisolone or prednisolone at least, because our digital gangrene was worsening. So that was the next decision point in this lady's course. So when we review the literature, we find that in rickettsial infections, especially like scrub typhus, although there is vascular injury by these organisms, it is direct impact of the organisms on the vessel walls and endothelium leading to that injury and vasculitic changes, rather than only inflammation leading to those changes. So in fact, there is enough literature available to say that except for very few scenarios where maybe retinal vessels are involved or there is severe aseptic meningitis, in rare instances as exceptions, in most other cases of severe rickettsial infections, giving corticosteroids is in fact associated with higher mortality. So the mainstay of therapy remains antibiotics like doxycycline, and in some cases, if needed, chloramphenicol. And that's how the patient improves. So even in our patient, without giving corticosteroids with doxycycline, over next 8 to 10 days, she did improve. Of course, the response does take longer when the initial treatment is started late, which had happened in this case because we were kind of uh, distracted, I would say, by that test of dengue IgM positive. So if we see a framework in this particular case, which could be very easily and commonly applicable to most of the tropical infections in our typical monsoon or peri-monsoon period, the first and foremost thing, start doubting your diagnosis when the disease is not behaving the way it is expected to behave. Of course, there can be some instances where even rare complications of a disease can be seen, but by and large, if the natural course is not fitting, start doubting your diagnosis. Secondly, when the diagnosis is based on serological test, and when in first question you have felt that the course is not fitting, always ask yourself whether am I relying on a wrong test or a wrong proof to support my diagnosis. And third, very important thing, when it comes to tropical infections, please pay attention to epidemiological clues. Now, after this, let us see the second scenario. So here I had one patient who was in his 40s with history of extensive travel within and outside the country, work related, almost every 15-20 days. And almost 3 weeks back, he had presented to a general practitioner with complaints of fever, which went on increasing over first 4 to 5 days, and that's when he was thoroughly investigated according to the initial doctor. And in that investigation, most of the tests grossly looked normal. Vidal was done, which was negative. Peripheral smear for malarial parasite was negative. Dengue serology showed IgG positive, and IgM and NS1 were negative. So at that time, initially he was treated symptomatically, but once the fever went beyond 5 days, he was empirically initiated on antibiotics. Now on these antibiotics, along with antipyretics of course, for 2-3 days he started feeling better, and then after 5 days course antibiotics were stopped, only for the fever to start increasing again after another 2 days of stopping antibiotics. Now this time when the reports were repeated, there was slight drop in WBCs as well as platelets. Again dengue serology and all the tests were repeated. IgG was still positive, IgM was negative. So this point of time, he was admitted elsewhere and he was started on steroids, considering that it is a dengue fever which is worsening. So they did LDH, which was something around 350s, ferritin, which was around 1000, CRP, which was around 110, and he was given IV antibiotics as well as dexamethasone. Again, while he was on these medicines for 3 to 4 days, he improved. Then the medicines were de-escalated, antibiotics were stopped in 7 days after switching to oral, and his fever recurred. So here he came to us. Now, on seeing his whole history, the patient had otherwise remained quite stable. So even after almost being 2.5, 3 weeks into the illness, and after 3 or 4 different courses of antibiotics, when the fever did not respond, but patient remained relatively stable. So now here we need to ask, are there any other subtle clues in this patient's natural course of illness and the lab investigations which point to something else? So when we looked at it closely and retook his history, he had a typical stepladder kind of fever pattern in the initial 5 days when he was not yet on antibiotics. Of course, later on all the courses and everything happened. So he had gradually increasing fever over 3 to 5 days. If we look at carefully towards the CBC, the differential count did show eosinopenia, which transiently improved during his first couple of courses of antibiotics, only to worsen again. And platelets and WBC, although they were low, they never dropped so low as we would expect in a dengue fever, or more so in dengue fever with macrophage activation or HLH like complication. So here, after understanding all these factors along with history of frequent travel, frequently eating outside food and hotel food, we told him that most probably this looks like typhoid fever or enteric fever. Paired blood cultures were drawn and patient was started on ceftriaxone 2 grams 12 hourly, and his temperatures were monitored. Now naturally, when the fever did not reduce at day 2, day 3, everybody started to panic, including the patient, patient's relative, and at times we ourselves get worried in such a case. But if we look at the patient, his vital signs started getting stable, that CRP which was elevated started to settle down, his blood counts were okay, eosinopenia had disappeared, platelets were normal. And when we asked the patient, he was saying, my fever is continuing, but I'm now kind of started to feeling better. I am feeling like eating. My bowel movements are better. I'm feeling more energetic. So this is another point where we need to really think whether we have to escalate antibiotics, thinking that it could be something other than typhoid, or even if it is typhoid, whether it is a drug resistant typhoid, well, ceftriaxone could be resistant, or I have to look at the whole diagnosis all over again, like we did in the previous case. So in typhoid fever, we need to understand that the blood reports like CRP, blood counts, liver enzymes, then the patient's sense of well-being and appetite, better bowel movements, all these things improve many times much before the fever improves. And being intracellular pathogens, these organisms, that is salmonella, are something which take little longer to clear, and the typical course is that after starting appropriate antibiotics in the appropriate dose, around 72 to 96 hours, that is 3 to 4 days later, the fever intensity and frequency starts decreasing, and only after 4 to 5 days, in some cases even 6 to 7 days later, the fever actually starts subsiding. So in this patient, 3 days later, we got a call from lab saying gram-negative bacilli are growing, which next day were confirmed to be Salmonella typhi, sensitive to ceftriaxone. So now, because the diagnosis is based on something which is gold standard and absolutely confirmatory, like a blood culture showing Salmonella typhi, there was no doubt that this was just a natural course of illness where it is expected that the fever will respond late. And we could reassure first ourselves and then the patient and continue the same line of management with which the patient later improved. As soon as he started eating well and fever started to reduce, he was switched to oral antibiotics, and complete course of 2 weeks of cephalosporin was completed, IV plus oral together. So in this patient, when he was not improving, again we should take a brief pause and ask ourselves, one, is the disease still behaving the way it was supposed to be based on the initial diagnosis which I thought of? Well, perhaps the answer was yes. Second, is my diagnosis based on something reliable like a blood culture, or something unreliable like a Vidal test or rapid card test for typhoid? And third, if all these things are like that, even when the patient is not improving in terms of fever, but if other things are starting to improve, do I really need to escalate antibiotics? So by doing so, am I overreacting or am I thinking rationally? And if we ask these three questions, then more often than not, we are likely to make better and more correct clinical decisions in such situation. Now coming to another scenario, which could be potentially in fact very dangerous. So we had this middle-aged lady who was diabetic for 4 to 5 years with kind of fair control, no other comorbidities, presenting with leg pain and an area of redness over the shin. And as you can see in the picture, it was a relatively well defined area of redness, warmth, and tenderness. So she was started on IV antibiotics. Her counts were 20,000, CRP was more than 100. And over next 2 to 3 days, even with these antibiotics, which were like standard ceftriaxone, which was started, and clindamycin, the patient continued to have fever. Her counts and CRP continued to increase, and she also developed acute kidney injury. Now, all through this, parallelly blood culture and various other investigations were sent. Antibiotics were promptly escalated to first piperacillin, tazobactam, then meropenem, but the patient's fever just did not improve. And she kept on saying that I have severe pain in my left leg. Now, within next 24 to 36 hours, she developed a very bright red swelling of the left eye with watering and severe pain. And the ophthalmologist examined and said there is a developing endophthalmitis. Now, this is when everybody kind of started panicking. And then whole lot of things like vasculitis workup and autoimmune panels and this and that. So many things were sent. So many new investigations were done. But after in all this chaos, when we took a brief pause and asked the patient again, what exactly are your other symptoms? She kept on saying, Doc, one thing which has not improved right from day one is my pain. And that time, when we made her show where all she is getting pain, she had severe pain and tenderness in the thigh region also. Whereas that area of redness, which was thought to be a cellulitis like thing, lower down on the leg, was way away from that area where she had severe tenderness in the thigh, and there were few red patches over her thigh like skip lesions, and she had tender lymphadenopathy in the left inguinal region. So even though the red patch and everything looked like cellulitis, at the bottom of it, we thought that it is necrotizing fasciitis and not just a simple cellulitis which is in the superficial skin layer. So there the surgical team was involved, and she underwent emergency debridement that day, and it showed black necrotic muscle and fascia all through her leg, almost extending up to the thigh. And parallelly also the blood culture which was sent, it had grown Streptococcus pyogenes. After debridement, within a matter of 48 hours, that lady's pain, fever, WBC count, CRP, everything started to settle. Acute kidney injury started to improve as well. Although eye-wise, she continued to require further treatment in future, which took a few weeks for her to improve. Now here, in this case, what is important is, first and foremost, the rule of clinical medicine, always listen to your patient. Your patient is telling you the diagnosis. So right from day one, although we saw a very small area of redness and thought a limited cellulitis over her leg, she was always telling of severe pain, which was much disproportionate to the area of redness that she had. So that is one of the important red flags towards the possibility of necrotizing fasciitis. Additionally, skip lesions, regional lymphadenopathy, immunocompromised patients are some of the things which point towards potential necrotizing fasciitis and not just a simple cellulitis, and especially in diabetic patients or immunocompromised patients. So, as a rule of thumb, we should remember that cellulitis is relatively superficial. So, it's like kind of the steady top layer of a sea or ocean. And but in necrotizing fasciitis, although superficially the skin may look calm, the area of redness could be limited. But lower down at deep facial levels, there can be infection spreading across the whole limb and threatening that whole limb, sometimes even requiring amputation if it is missed. So just because there is no gangrenous patch, no blackish discoloration, we should not think that there is no necrotizing fasciitis, because if we wait for those things to occur, it could be already very late for that patient. So in necrotizing fasciitis, it is the scalpel, that is the surgery, which patient requires much more than your syringe or stepping up of antibiotics. So actually after this diagnosis, she just received simple ceftriaxone and later on oral cephalosporin, with which she improved reasonably well, because strep pyogenes, as we know, is by and large pan sensitive, and even penicillin resistance is not so common in Streptococcus pyogenes, unlike your Streptococcus pneumoniae. So friends, like we saw from these three cases, whenever we see that a particular patient or his signs and symptoms are not improving, we should start questioning three basic things. We'll call this a 3M framework for a patient not improving. First, the disease itself. So if the disease course is not fitting in the disease that you diagnosed in the beginning, start questioning your diagnosis. Second, the severity of assessment. So the assessment of severity. So if the disease is a diagnosis is correct, but certain things are not fitting in that diagnosis. So always think whether I'm missing out on some complication of this particular disease. And third, the tests which are used for diagnosis. So is my diagnosis based on a reliable test, or it is based on something which by itself is shaky, making that diagnosis 50-50? If we are able to step back, apply these three questions, answer these three questions, then more often than not, we'll think more clearly, because in such situations, we don't require more sophisticated tests or higher antibiotics and stepping off of treatment. Sometimes all we need is more clarity in thinking, analyzing the whole situation in a unbiased way, and then making correct clinical decisions. Contrary to all these scenarios, there are some scenarios where everything seems to have been done correctly, and a patient who is relatively looking stable suddenly deteriorates. That's a completely different ballgame. That's what we'll discuss in our next video.